you. Hello, and welcome to today's Expert Insights webinar from Wolters Kluwer. Before we begin today's session, there are just a few housekeeping items. The session is being recorded, and the recording will be made available to all attendees. Your lines have been muted to minimize background noise during the presentation. We encourage you to submit a question in the Q&A box at any time during the presentation. Questions will be addressed during the Q&A session. Should you need technical assistance, as a best practice, we suggest you first refresh your browser. If that does not resolve the issue, please type your concern in the Q&A box, and a technical representative will reach out directly to provide assistance. We will now begin the webinar. Vikram, over to you.
Thank you, Shannon, and thank you very much to our audience for joining our Expert Insights webinar series. I'm Vikram Savkar, General Manager for the Medicine Business at Wolters Kluwer, and I'll be your moderator today. Even before COVID-19, it was a time of significant ferment and innovation in the medical world more broadly and the medical education world more specifically. Availability of new technologies such as virtual reality and artificial intelligence, changing demands of consumers and students in a digital age, and shifts in public policy and investment have all combined to create an environment in the medical world of continual exploration and experimentation. The COVID-19 crisis has added significant urgency and momentum to these activities. It's clear that the pace of innovation will and should accelerate in the coming years. This webinar series is designed to help socialize these emerging ideas across the community. Our program today will be focused on the innovative and emerging practice of health design thinking. The webinar is called Implementing Design Thinking in Medical School to Develop Creative Problem Solvers. I'm delighted to welcome our guest today, Dr. Morgan Hutchinson, Director of Education at Thomas Jefferson University's Health Design Lab. She is an emergency medicine physician and the Assistant Medical Director of the Emergency Department at Thomas Jefferson University Hospital. Dr. Hutchinson is on a mission to improve healthcare by training doctors to think like designers. Her work focuses on the application of human-centered design to medical education and healthcare delivery. Joining Dr. Hutchinson today are three Thomas Jefferson University students who will be sharing their final project: Martina Rama, Jenna Mandel, and Sarah Belko. I'm excited. This is the first time we've had students as a part of our webinar. I'm very pleased to have Dr. Hutchinson and her students join us today. And with that, Dr. Hutchinson, please take it away.
Thank you so much for having me. It's a pleasure to be here. I work in a research group at my hospital called the Health Design Lab. And in the design lab, we use a creative and human-centered approach to solving problems that we see in healthcare. We bring together people from both inside and outside of the walls of the hospital to address and solve these problems. And we use an approach called design thinking to understand these problems, build empathy, and find creative solutions in real time. Let's take a step back. My first experience in clinical operations and design thinking happened when I was in medical school, before I actually knew what clinical operations or design thinking actually were. I was able to work with a team in my medical school to create pop-up clinics in both Ghana and Nicaragua, and I absolutely loved this process. It was an opportunity to create a service for a community, to work with community members and find solutions that fit their needs. And I didn't actually know what I was doing at the time, but I did know that it was something that I really loved and I wanted to continue to do. So 10 years later, I have this amazing opportunity to be teaching my own medical students the concepts of design thinking in the first curriculum that has been designed in a US medical school to teach design thinking to medical students. We teach students to think like designers, and we give them the tools that they need to be able to harness their creativity, and address the problems that they find in the hospital. So what is design thinking? Design thinking is an open mindset rather than a rigid methodology. It starts with the needs and the desires of people. Design thinking involves observation, conversation, research, and collaboration, and we are already doing these things as physicians. It encourages an open-minded and open-ended exploration, and not just a straight path from problem to solution. We encourage questioning, visualizing our thoughts, creating tangible prototypes, and telling stories about the people, ideas, and outcomes that exist within these problems. To teach non-designers how to think like designers, we break down the design process into these three main phases: observation, looking, listening, asking questions, and gathering research; imagining, generating multiple ideas, sorting them out into groups, looking at relationships and analogies, and deciding how we can move forward; and making. This is a hands-on and physical process. We create prototypes, share them early with each other, and get feedback. And a prototype can look like many different things: acting, building, drawing. One thing that is essential to this process is co-design. This is the process of collaborating with users and community members to solve problems. We work with end users and we gain empathy. Empathy is a core principle of health design thinking. It is the ability to share in the experience of another human. To design healthier communities, we seek the expert knowledge of the users of different parts of the healthcare system, and we involve them early on in the process before we've actually created a solution. Creating a how might we statement is an important part of gaining empathy and keeping an open mindset. So creating a how might we statement keeps us focused on the problem instead of jumping to solutions too early. How might we help X person solve Y problem because they're feeling Z? These are all very important parts of the design process to break down. Who are you solving a problem for? What is the problem that person is experiencing, and why is it a problem for them? Redesigning healthier communities is an essential part of this process for us. So we focus on the most vulnerable communities and the most vulnerable patient populations in our city, in our hospital, in our healthcare system. How might we make the system more equitable for them? How might we make it more accessible? We use the concept of questioning in this process. We are constantly looking critically at our solutions and questioning them from different viewpoints. Once we've identified the end user that we are solving for, we're able to start to define the problem and work to understand the problem space. At this point, we're able to start prototyping. Prototyping is a way of sharing our ideas with others, and it allows other people to interact with our ideas and give us feedback. And prototypes don't have to be high tech or complicated. At my medical school, I encourage my students to start with Legos, pipe cleaners, acting, duct tape, many different tools like this to give a physical form to their ideas. One type of prototype is called a storyboard, and here are a couple of examples. A story consists of a significant action that's taking place over time. And these are some examples that our students have created. One important part of this entire process is to get feedback constantly as we're going through the process. So a feedback capture grid is a way that we teach students how to give each other feedback and how to learn from the feedback from one another. Sharing early prototypes is essential to this process, and getting feedback that is useful and helpful and constructive is essential to that as well. What is good about your solution? What is confusing? What needs improvement? What questions do you have when you hear someone's prototype? And finally, what are your new ideas? These are all questions we can ask others while we present our prototypes, and they can lead us to the insights that we need to move our projects to the next step. Visualization boards are an important part of this process for our students as well. Currently, we're using a virtual whiteboard, but this is our more standard version on a big cardboard poster. The teams collect their work on these visualization boards, and they're able to build their prototypes, allowing everyone in the team to see their progress and everyone to see the insights that have been gained and the anticipated results of their project. So how do we practice what we're teaching? During the pandemic, we already knew that the zip code that you live in Philadelphia is the greatest predictor of your life expectancy. In Philadelphia, like many other cities, the zip codes with a lower life expectancy are predominantly communities of color. And these are classically food deserts, healthcare deserts, and education deserts. People in these communities lack access to the basic things that they need to be healthy. And during the pandemic, the death rates in these communities were twice as high as they were in other parts of the city. They were becoming testing deserts and vaccine deserts. We believe that if someone wants to get a test in the United States, they should be able to get one. So how might we expand testing for these patients because they're living in these areas where they don't have access? We wanted to make testing as easy as ordering food from a drive-through. So we designed these no-hassle sites where people don't need insurance, appointments, or orders, and they could walk up or drive up at any time. The pandemic didn't only create new challenges in these communities, but it also amplified the challenges that existed. So we worked together with our team of community health workers to connect each patient with a community health worker who could help connect them with multiple needs in their health and in their non-health journey. So as we started testing in these communities, we saw that the second wave had begun. And we started to deal with new problems, supply chain shortages, lab capacity, and we had to start questioning the prototypes that we had created and creating an iterative approach to what we were offering with these communities. And this is an example of one of the changes that we made during that time. Our lab partners were unable to keep up with our increased demand, even though we were able to develop an operational plan that could expand to more than twice our original capacity. And so one thing that we did was add point of care testing. So we could offer every patient a rapid test on site and connect them with a provider who could help to counsel them in their health journey as well. Another thing that we added to our operation was contact tracing. So early contact tracing is essential, as many of us know, to containing the virus and to preventing spread in the community. We were able to add on-site contact tracing to our program. So now a patient could come in as soon as they decide they need a test, get the test, speak with a provider, and get a contact tracing interview in just a number of minutes, and often without even leaving their car. Patient journey maps like this one show multiple different layers of a user's experience over space and time. And this allowed me to share these operational plans with community members, with the community leaders, and with my team to gain feedback and think about how this would look from each person's perspective. Now I'm launching vaccine sites in vulnerable communities, and I've learned so much from the process of testing. By creating a fully mobile operation and a flexible staffing program like this, the program can have more impact by moving from location to location based on where the need is at any given time. This year in my medical school, I gave our students in the first year of our medical school this design challenge. How might we redesign healthcare delivery during a pandemic? And their solutions ranged from improving the wellness of nurses to helping connect patients with family members to keeping our hospital green despite the increased PPE waste during the pandemic. And it's my pleasure to introduce 3 of our medical students who are going to be sharing their design solution and talking a little bit about their process this year as they develop their solution. So Martina, Jenna, and Sarah, over to you. Thank you.
Good afternoon, everyone. So as you've heard from Dr. Hutchinson, our first year of medical school has been definitely a bit different than usual. We started medical school in July of last year, where the impact of COVID was heavy, not just in the US, but really worldwide. And for us, the school asked us to start school in a basically completely virtual learning environment. We had no real options for patient contact, and we really didn't have any chances to meet our peers. And for me personally, patient contact and the interpersonal aspect of medicine was one of the factors that really drove me to the field. So it was definitely very frustrating, and it was very scary to not to be able to meet any patients or any peers to go through the process together. But when we actually had our first session of design and started our design course, we were given a problem to solve: redesigning healthcare delivery during a pandemic. Easy problem to solve, right? So we started out by reaching out to family and friends who had experiences in the healthcare system at the time. And one of the very first people we talked to was Sarah's father, who was scheduled to undergo surgery at that time. And he talked to us about how he felt anxious about the fact that he couldn't have his family by his side during the process, given the hospitals had recently implemented these new no visitor policies. After talking to him, we talked to family and friends who were nurses and doctors and providers in the ICU and ED departments. And they told us that things in the ICU were absolutely crazy, and that it was very difficult for providers to bridge the communication gap between the families at home and the patients in the hospital, and how they felt like they were not really able to emotionally sustain their patients like they wanted to. So at the outset, it seemed like there were some recurring themes, and these themes were that people felt anxious, they felt lonely, and they felt isolated. And one other important point that was highlighted during all of these conversations was the fact that older populations were really more susceptible to these anxieties. In fact, when we think about technology, it's easier for younger people to have access to smartphones and be able to FaceTime or face call their families, while instead these resources are not necessarily available for the older population. So we had learned that COVID had not only changed the way the medicine was delivered, but it also had a big impact on external factors such as emotional support that can then affect health outcomes. So this really led us to develop our own question that would then guide the rest of the design process for us, which is, how might we improve patient isolation in critical care units during a pandemic?
So design gives us the tools to solve these new problems. So imagine a broken house. This broken house has a lot of problems and needs fixing. On one end, you have the inspector or the researcher who actually sees these problems. And on the other hand, you have the engineer or the developer who actually fixes this house. So bridging the gap in between those two, we have the architect or the designer to actually design the solutions to these problems. So very similarly, we identified our problem of patient isolation during the pandemic, and we as the architects were able to bring to life an idea for this solution, which you'll hear about shortly. Just like architects have their tools, designers, we also have our tools in our toolbox. So one of which is the user persona. So we identified this problem, but we really wanted to narrow down our scope into who were we actually designing this for. So this is Roger, our patient. He's a 78-year-old man who comes to the ER in critical condition, likely due to COVID infection at the time. And he finds himself in the ICU without his family. He's very scared, and his motivation is to get back to his family as soon as he can. Another tool that we had in our toolbox was the storyboard. A picture is worth 1,000 words. So this is going to show Roger's story. So Thursday, April 22nd, Roger was playing with his granddaughter and his wife, and when there was a sharp pain in his chest. Grasping for air, he grabbed onto his wife, who immediately called 911. EMTs came to take Roger away to the hospital. However, because of COVID restrictions, his wife couldn't go in the ambulance with him, so she drove to the hospital separately. There, she found that she couldn't even enter the hospital, which made her very, very upset. After being stabilized, Roger wakes up to a bunch of scary monsters in white coats, plastic masks. You can see no one that he knows. All he can see is their eyes and hearing a constant high-pitched beeping. All he could think about was his wife and where she was. So for Roger, after being lonely in the hospital, wishing to see his wife's face, the solution suddenly appears.
So say goodbye to visitor restrictions and say hello to Connie. Connie stands for Connecting Individuals Externally, and it is an application-based software that can be downloaded from essentially any smart device. It's made to connect patients inside the hospital to their family and friends outside the hospital. So when we started to, get into our problem-solving process, we thought to ourselves, okay, well, there's a lot of great technology that's already out there. How can we leverage the existing technology to just make patient communication easier and more seamless? And we really wanted to address this digital divide. So our patient focus was making things easier for the elderly, making it easier for those who maybe can't speak or can't move, and addressing all of these communication barriers in a way that does not add to the already hectic workload of the hospital staff. So you guys may be familiar with the way that we interact with things such as Siri and Alexa, and Connie functions similarly. It's a voice activated system, so our patient Roger can say, "Hey Connie, call my wife." It's also a one-touch system, so if somebody's unable to speak, it's very easy to navigate and there's essentially no learning curve. From the provider's perspective, it can be customized and tailored to the provider network. And finally, it can be integrated with the existing electronic health record. So if Roger was previously a patient at, for example, Thomas Jefferson University Hospital, and he comes into the emergency department here, his contact information will already be populated into Connie's software, making it easy for him to connect with his family and friends without any additional work. So when we started to really come up with our focus area and hone our intent on bridging this isolation gap and problem that was growing, greater during COVID, it was around September that we started to focus in. And at that point in time, the emergency department staff here was kind of working on the same problem in parallel. So they had asked us to come and present our thought processes to them, and our joint forces ended up helping them create the solution that they're currently using in the hospital today. So ultimately, why are we here? Why is design great for medical students, and why specifically has it been awesome for us? So Martina kind of opened this up by telling you how the three of us are first year medical students, and this year has been a little bit different than we might have imagined it, and kind of hard because we're going into this profession to have a connection to patients. But the great thing about this has truly been this design course and track. It's honestly been my personal favorite part of this entire year. It's given us the opportunity, as we said, to really engage in an effective and collaborative way with the hospital department and kind of see our ideas take form immediately and benefit our community. And it's also given us the ability to really reach out to the patient community that is, in our direct surroundings and kind of assess what their identified needs are. And in doing all of this, it really builds our empathetic approach, not only to patient problem solving, but just thinking in general. And I personally feel that this empathetic thinking is really going to drive our success as providers and really help us be better for our patients. And at the center of all of these things is the Health Design Lab, which has really given us the space to build on these skills and work together to come up with these, critical solutions. So that leads us to our final question for you guys, which is, what is your broken house and how might we train more architects to fix it? Thank you so much for having us.
Well, thank you very much to Dr. Hutchinson, Martina, Sarah, and Jenna for extremely thoughtful and thought-provoking presentation. We're going to move into the QA section now. I want to let all the attendees know that you can type a question into the Q&A box, and I'll be looking at those questions as they come in and relaying them to the attendees. But I will start, as I always do, with a few questions of my own, and I will give those to you, Dr. Hutchinson, and then you can decide whether you or one of your students is best placed to answer it. But really interesting to see the path that led to the creation of Connie, and exciting to see that Thomas Jefferson University Hospital took it up and implemented it. So the first question that I have is, how did it go once they started using it? How did the development go? How was the experience for patients? Did it make a positive difference? So bring us up to date on the impact that it's had so far.
So I think one thing that's important in this process for us to, for all of the groups to understand about their own solutions is that once we come up with a design solution for a community, it will change a lot and it will be tailored to the individual department's needs. So as Jenna was mentioning, early on in the pandemic or early on in their design process, the emergency department was looking for solutions and thinking about the way that this team implemented solutions similar to FaceTime, similar to Alexa, similar to a lot of things that already exist. The team sort of influenced our process to use another existing software plan that we have that's through our electronic medical record in order to connect patients with their family members. So it looks significantly different than Connie. The development of this app specifically is still being worked out, and it was proposed as a project for this coming year as well, so they can continue sort of developing it specifically.
Good to know. And that, but you're the expert on design thinking, so I will just ask you, would you say that that's a really good example of design thinking, that an idea morphs and has an impact and takes a path that's sort of organic?
I think that's a pretty universal thing that happens when we are thinking about how to design for communities. So we start with the whole process of gaining insight from the community members and from the stakeholders and the users, understanding what the underlying problem is and really trying to create a solution that will work for them. And as soon as we implement that solution, no matter what it is, a testing site, vaccine site, Connie, or any of the other projects, it will change pretty significantly. And that's not a failure. That's just a normal part of the process to see that, you know, once we implement something, if it's successful, it will continue to change and develop over time as it starts to be used and implemented. And what we can do as designers and as the architects in this situation is to help guide that process and to help respond to those to all of that feedback that we're getting about the solution, so we can keep developing it better to fit the needs of the users.
Thanks. I'm going to jump to a completely different topic. I'm going to jump around a little bit, and then as the attendee questions come in, I'll jump over to their questions. But I've got a few of my own that I want to stick with. So you talked about your work with mobile units, and I think it was Ghana you mentioned, and a few other places like that. So you've talked about how at the heart of design thinking is empathy. That's part of what makes it special, and that's part of what makes it valuable. What are the challenges of achieving that in a culture that's so different from our own? How do you get to a place where you feel like you genuinely understand the people you're working with, as opposed to feeling like we understand? You know, these are always challenges going into a culture that's so different. So I'd be interested to hear you talk through that.
Thank you. I think that part of that, that's a very, very important part of design thinking, exactly what you're sort of framing here. And the important thing is to just embrace the change, to question the solutions that you've created, and the best solution with the most empathy and the great understanding of the users will still undergo many changes. And so embracing the feedback that you get once you implement a solution, and embracing the feedback that you get about your solution and whether or not it's feasible, and helping the users sort of work through how they can implement something that really fits their own needs is essential. And so looking at other communities, you know, we start with you know, working in other countries especially, it's important to really understand the system and the resources that exist in those communities. And so we are able to sort of work with the community health workers that are local, who can help to connect patients with external partners, So really, it's a lot of coordination on our part, and a lot less of the actual delivery of the specific end of the healthcare service that we're going to be giving to patients, and more about kind of developing the tools and the resources within the community that already exist to help patients get the care that they need.
Makes sense. Let me switch to a different topic, and I think this is more for the student team. So on a similar theme, you said you started your project with, I think it was Sarah's father. You mentioned had some feedback that sort of sent you off down this course, but then as part of your project, you must have had to talk to or learn from or read about many different kinds of patients, and you wanted to design a solution that spoke to a broad set of people, and a hospital emergency room is a very, very diverse group of people. So how did you think about the challenges of understanding all those people from all of their communities and finding the right empathy with them to make sure that the solution that you designed was relevant?
So I can speak to the beginning, and then Sarah and Martina, you guys can add on to this. One of the, I guess, tools that we use in this design thinking approach is in the process of creating a user persona, we're essentially coming up with an imaginary character. They're somewhat imaginary, but they're really based on our preliminary outreach and interviews with people who have been immediately affected by whatever the problem area is that we've decided to solve. And for example, in our presentation, we were discussing Roger, a 78-year-old individual. And so we would have spoken to patients and providers who have cared for somebody in that category, or the patient themselves who was experiencing it. And then as we go through the process, we kind of put ourselves in that person's shoes and think, what are they thinking? What are they seeing? What are they hearing? And where is there room for improvement here? So from that, and we do that from every single stakeholder's perspective. So we define all of our stakeholders, we define where we think we want to solve a problem, and then we start to figure out what it looks like from everybody's lens. And with the three of us, when we were developing our process, we kind of had multiple stakeholders. And at the end of the day, there was this thread that we thought, okay, well, we can make this specific to one patient population, but at the same time, we think that down the line, it can actually be beneficial for a lot more than just this group.
Thank you. And do either of the others want to add on to that, or is that good? They're good. Okay, good. Thanks for that. So I have a question now for Dr. Hutchinson about this course or this approach as part of an educational curriculum. So I think clearly your students are learning skills that they will apply when they are professionals. It's hard to think of anything that we do that doesn't benefit from empathy, thinking about the people we're working with, looking at things from their perspectives, whether it's practicing medicine or doing business or anything in the world. So it's a really practical skill for professional life. How do you view this as an educational experience in and of itself? Do you view it as skill building? Do you view it as part of the curriculum, helping prepare students for their boards and that kind of thing? Interested in where you see it situated in terms of skills versus tangible knowledge and so on and so forth.
I think that as these three students have sort of highlighted very well, that it's important as as you're beginning the medical school experience to feel connected with patients, because when I was a first year medical student, that's exactly what I got to do, and I loved it, and it was so exciting. And I can't imagine how difficult it would be to start medical school during a pandemic and not be able to experience those things while you're studying for the boards. I think that in a traditional year, and also during this year, it's important to develop those skills that we already use as doctors all of the time: gathering information, gaining empathy, understanding problems, and thinking about how a patient will solve those problems. An example that is pretty typical in medical school is, what prescription would you give a patient? If a patient is not going to be able to take 5 doses of her prescription per day, that medication is not going to work for them, even if it's the #1 medication for a certain problem. And so I think that thinking through problems with a design thinking approach not only helps to solve big problems like connecting patients with their loved ones while they're in the pandemic and their loved ones can't visit them, but it also helps to think through your approach to talking to patients and coming up with a solution for individual patients as you're developing their own plans. So I would definitely say that it's more of that skill building approach to patient care, rather than specifically to help pass the boards.
Great. And then we've got a couple of questions from attendees that are, I think, along the same lines. So there's one question for the students, to the students. Did this help you stop focusing on only studying for what may potentially be on an exam and how you can apply knowledge you were learning during didactic? So I think a similar question. Did this shift your perspective on what you were trying to accomplish in this semester?
I can answer that question. From my perspective, absolutely. I think as medical students, we're all inclined to spend all of our time studying. So having a built-in break with a program like this that really structures in time to be doing some extracurricular things was great. So that really helped for me managing my time. And also it was just very, very nice to look at things more from the patient perspective. Like, for example, when we were doing our Connie project, we had to tour some of the rooms in the ED and ICU department. So we were able to actually see like, what does it look like when you're a patient? What does the room look like? How does it feel like to be in this room? What is available around you, and really put yourself in their shoes. And then again, I think depending on the project you embark on, you can also have opportunities to actually, see some of the knowledge you've acquired apply. I think it wasn't that evident for us just because we were working more on a software-based project. But I know some other students have had those opportunities as well.
I just also wanted to add that beyond the actual project itself and like looking at the patient perspective, I feel like design in this course also helped us kind of like expand past what we were currently learning in medical school and kind of look into our career of how we want to incorporate design in our career long term and kind of what patients we want to work with and what type of devices we want to kind of come to in our careers.
Thank you both. Dr. Hutchinson, you chose this group of students because their project was very interesting and very successful, but you had many groups of students. Were they all successful? Some work, not work? I'm not asking, because we want to know if there were people who didn't succeed. It's more to get a sense of what kinds of expectations are appropriate to have when you take this kind of open-ended approach to education.
So multiple groups were very successful. As I sort of mentioned during my talk, my interest in design sort of comes from my interest in clinical operations. And so I run the clinical operations of our testing and vaccine sites. I help run the clinical operations in our emergency department. And as we were listening to the final presentations, I started to think about it as, reasons, all of the group's solutions as reasons that you want medical students involved in a clinical operations team, because they look at problems with a very fresh perspective, but with a lot of insight from both the side empathizing with patients and also the side of understanding the system that they're working in and that they're learning about. So various other students did a lot of successful projects. One of them just made a video that was shown at a Celebration of Innovation conference. One of them submitting an IRB right now. One of our groups is also working really closely with the emergency department and with some other groups to develop solutions for PPE waste. So there's many awesome groups. I have no favorites. All of them are my favorite. You guys are my favorite, and so are all the rest.
Very good. So there's a question from an attendee to you. How do you stimulate curiosity and questioning skills in the students so they can come up with the problems? So I would assume that you would say that a really interesting solution has to begin with a really interesting problem. So how do you stimulate your students to come up with interesting problems? Or is there no such thing as an interesting versus an uninteresting problem?
I think that depending on how you look at it, an uninteresting problem can become interesting for sure. And I think that a lot of examples in clinical operations, when you think about it from a conventional, here's the problem, come to a solution, linear path, it gets a little bit boring because you're thinking about a problem that somebody's already defined for you, and you're not really questioning it. You're not really creating prototypes. You're just going from problem to solution. And so I think that the process of actually teaching people the skills that you need to be able to implement design thinking into problem solving is all you really need to make a problem interesting. And the silver lining this year is that we have so many problems that exist during the pandemic that don't have solutions. And there's so many problems that that a lot of us in healthcare don't have time to really think through the way that these students have thought through their solution with Connie. And so I think that from beginning of the year, giving them the challenge, a broad challenge that's narrow enough to suggest a direction, but broad enough to sort of have an umbrella over all of these different solutions, ranging from focusing on nurses to patients to family members to thinking about like the hospital's waste in general, is really important as we're kind of thinking about the how might we statement that we give to students to have them develop their own how might we statements, and then giving them the skills that they need to kind of take that how might we statement, think through who the users are within their own interested project, and give them the skills to gain the empathy, to create the prototypes. I think that the interest kind of comes with having those tools and having those tools developed.
That's good to know. It's the journey. Would be my summary of what you're saying. That it doesn't really matter what the starting point is, but if you approach the journey in the right way, you'll find something interesting, something thoughtful to do. I'm going to switch gears again. You're on the front lines of the vaccine effort, and you have been now for a while. And of course, the really big topic right now is vaccine hesitancy. And as a country, we're getting to the point where that is going to become the critical problem. Our first problem was getting vaccines into the hands of people who wanted the vaccines, and now we're pretty close to the tipping point of needing to focus on the rest. Is that something that design thinking can address? Is that something that design thinking is addressing? Are you and your colleagues thinking about sort of design-based approaches to that? I hear all kinds of interesting things. You hear in certain cities, I heard one city, people gave away a free beer if they went to a bar and got their vaccine, and amazingly enough, it appears to have worked, and 100 people were lined up. So there are all kinds of ideas being tried. How do you approach this from your perspective on the front lines?
That's an excellent question. I certainly spend about 12 hours a day thinking about that question, if not more, and talking to my colleagues about that question. I think that what's important to understand as the providers of healthcare is that there's a whole population that we would like to get vaccinated, and who should get vaccinated, and who we believe that getting vaccinated will help end the pandemic. And there's a portion of that population that would rush to any site to get a vaccine because they're excited to get that vaccine, and they're proactive, and they're willing to do what it takes to get the vaccine, stay on hold for a long time, wait in line for a long time, go to a site that isn't necessarily the most comfortable or like nice setting, like big mass vaccine sites. So those people have been vaccinated now. And so we're looking at the rest of the population, and the rest of the population isn't necessarily vaccine hesitant. So one of the cool things that our sites do that is unique about us is we have a phone line that is staffed 9 to 5, Monday through Friday, and we call back all the voicemails from the nights and weekends as well. So in the first few days, week or so, and then intermittently since then, I've been helping to cover the phone line and talking with patients. And a lot of people haven't gotten a vaccine because it hasn't been convenient to them, not because they don't want to get a vaccine. As soon as they have that quick conversation with someone who says, oh, we're here in this school, in your son's school today, we can get you a vaccine, would you like to come in? they're very excited to come in and get the vaccine. They don't need to be talked into it. They just need that comfortable and inviting and convenient experience. And so I think that, you know, that's been a huge learning point for me, is that we're kind of ignoring that part of the population. Everyone assumes that because you don't want to go to a mass vaccine site, wait in line, stay on hold, that you may be hesitant towards getting the vaccine. But I think that a larger part of the population is not hesitant. They're just busy. They have kids, they have multiple jobs, they might not have a car. We're finding that language is a big barrier as well, that people are afraid that they're not going to be able to understand the process, and they're hesitant because of that, but not because they don't want the vaccine. They're hesitant because they're being asked for their insurance and their social security numbers. They're hesitant because they're being asked for their IDs and they may be undocumented. So we're 100% working with many different community groups, and I think that's essential, to be working with community groups to help with the recruiting process. We are working with community groups who represent the Southeast Asian immigrant refugee population in South Philadelphia, and multiple community leaders from schools, churches, community centers, and some of the Black and Brown communities in Philadelphia. And we've been very well received in all of our initial efforts. The neighborhoods are very supportive of us. They're calling their friends and family, telling them to come over to get the vaccine. And I think that kind of, you know, personal touch is very important to people kind of overcoming whatever hesitancy they do have, or whatever barriers they've found to actually getting a vaccine. You know, I can empathize with these people, because I am admittedly, doctors are terrible patients. I'm a terrible patient. I don't want to call. I don't want to wait on a hold. I don't want to make an appointment. I don't want to sit in the waiting room and wait in line and spend my whole afternoon somewhere. If somebody comes up to me and says, oh, hey, we can do that lab that you didn't get last year that you're probably never going to actually get, we can just take you right now and get that done. That's awesome. And that's kind of the response that we're getting from a lot of people in the communities.
Thank you for sharing so much about that. It's not related to the class that you taught, but it's hard not to ask about that since you're on the front lines, and I think everybody on the webinar is really interested. I'm going to switch to an attendee question. Can you speak more to the design course? What is the theory you are using? Is it engineering based? How does it integrate with the rest of the medical curriculum?
We are teaching some of the basic concepts of design thinking to the medical students. And so our first year curriculum is based on, each of our classes are based on different parts of that teaching. So iteration, defining the problem, gaining empathy, those are the titles of some of our classes. And so as we go through the class, we also do like prototyping, and that's sort of the process as a first year. We're focusing on the first year's curriculum today, because I think that's one of the more involved and like interesting, relevant years right now. Our second years are able to sort of define their own problems. So we let them decide on what problem they'd like to address now that they have these skills developed that they learned during their first year. And then during their third year, students are actually working individually, identifying problems that they come across in the hospital during their clinical rotations, and focusing their design solutions on those.
And is it a required course for all M1s and M2s, or is it an elective essentially?
It's an elective. So at Sidney Kimmel Medical College, we have a program called the Scholarly Inquiry Track. So it's a longitudinal 4-year track that focuses on students' area of interest. So research, design, community health, humanities. These are some of the sort of broad themes of the tracks. So the students choose and apply for the track that they prefer.
I'm going to jump to a question to the students. So the 3 of you worked together on this project. I'm assuming that you weren't able to see each other face to face very much. You did most of the project the same way we're doing this webinar. Was your work together as well coordinated as your presentation today, or did you have challenges? How did you get through the challenges? I'm curious how you worked through this process of three people with perspectives and opinions arriving at a common purpose.
So one of the devices, or not devices, but tools that we used was something called Miro. It's spelled M-I-R-O, and essentially it's a virtual whiteboard that kind of has no bounds. And that was our core, where we were able to really have that, mimic that like Post-its on a whiteboard type of situation and have a lot of our brainstorming take form there. Outside of that, we just stayed in communication by, texting and group me's and other group chats. Sarah, did you want to add something?
Yeah, I just wanted to ask that also, like, we all have very different backgrounds coming into this project, and just like respecting each other's background and each other's insights has been a great thing. Personally, working with Jen and Martina has been one of the best things about this year for me. And in terms of a team, we didn't have any problems, and we felt open to share our opinions and like do our interviews together. So it was definitely just different backgrounds coming together to do one problem.
Martina, anything to add?
No, I echo what they both said. I think, I don't know if I was just lucky and had two really good teammates, but I think we worked really well together. And I agree, like Zoom can be a bit challenging. We did have like almost once a week a Zoom meeting to kind of catch up and align on the things to do next. But I think you get used to it, as with everything. So it ended up actually working very well for us. And I think it's been a great, in general, the design program has been great as far as practicing teamwork and dividing up the work, and then also trying to give to each team member maybe the things that they're best at, so that you can have the best possible product. And then also has been a great lesson as far as giving feedback to each other. I think for me personally, I'm always a bit reluctant when it comes to maybe, giving negative feedback, not truly negative, but like saying something that maybe I think could be improved. But I think this program has really given us a chance to speak very, very openly about things and try and make each other the best we can.
Good, thank you for that. So there's a question from an attendee, again for you, Dr. Hutchinson. How do you assess the student knowledge for accreditation standards, national exams, and so on? I mean, this is a very different kind of class. It's very different from learning a set material and then assessing them, but what is your assessment framework? It is still a class. I assume you still have to give a grade of some kind. How do you assess students?
So each of the scholarly inquiry tracks are based on sort of developing some of the professional skills that will benefit you throughout your career. And so we assess based on very similar sort of parameters, the quality of writing, your written proposal, the methods that you use to come to your solution, your proposed solution, and how feasible it is. These are some of the main categories that we sort of think about during assessment.
Good, thank you. Question from an attendee. Very interesting question. Any thoughts on making an interdisciplinary project with other allied health programs? It would be interesting, to combine with the nursing program and so on. I think that's what the attendee is thinking.
That's, I think, a perfect question for these students, because you guys are actually doing Jeff Solves, which is sort of a summer intensive program that we run in collaboration with Industrial Design. Sarah, do you want to take this one?
Sure, I can take part of it. So as Dr. Hutchinson just said, we're working with design students at our East Falls campus of Jefferson. So being in a collaborative group with about 2 or 3 medical students and 1 or 2 industrial students, we come together, and we've been doing basically all of this design process that we've been telling you about in terms of like interviewing users, interviewing patients, as well as kind of narrowing down to a how might we statement. And then moving forward into the summer, we're going to be prototyping and doing IRB approval to like test on patients and things of that nature. So this like interdisciplinary project has definitely, it's helped as a medical student, like talk to and speak with other people in the field. So like our industrial design students, and understanding and be able to convey and talk professionally about our topic and things of that nature. In addition, it's like giving us different perspective of like, oh, someone in an industrial design course might look at our problem, differently than we are, because we're looking at the patient and the disease, not necessarily like what it might look like, or the stigma behind our problem or our solution that we're coming up with, and things of that nature. Also, Jenna's in the Jeff Solves program as well. Do you want to speak to anything, Jenna?
I think you covered it nicely. The interdisciplinary teamwork is just key for gaining that extra insight. And like Sarah and Martina were previously mentioning, just kind of bringing in everybody's background expertise into one forum.
Good. Thank you both. I think we have time for one last question. We probably have about 2 or 3 minutes. And I'm going to relay this to you, Dr. Hutchinson, and I'm going to go back to the vaccine topic because I think it is uppermost on people's mind. One of the elements of a design thinking approach and so on that's exciting is that it works because it's built around the real needs of real human beings. The idea is that you get to a solution that's actually effective. And I think the sum of your answer on working with community organizations and so on was all about being patient-centered and human-centered. One of the challenges, it seems, is scalability. It's so much easier to imagine passing a national policy and then thinking that 200 million people will just do what the policy wants. But as you illustrated, it's more complicated than that. It's community by community, it's organization by organization, it's group by group. And how do you think about the scalability aspects of design thinking? How do you take the benefits of the approach that you use and achieve it at scale as well? How do we think about that as a society?
I think from a couple of different perspectives, from a medical school perspective, I think it's a very important part of the curriculum that really does add a lot to the way that you approach individual patient care and how you approach problems that you'll come across during your own career, and how you'll approach, clinical operations issues like running a vaccine site. So I think that it really does give me that perspective to think about solutions from, a different lens, and thinking about how my solution is working and not seeing changes as a failure, but seeing them as an opportunity to improve. I think that whole mindset is very important for us to have as we're developing solutions for communities. From a vaccine side perspective, I think that there's a lot of important issues with scalability that, creating a sustainable model means really understanding it from various different perspectives. And so being able to create something that is accessible to patients, but still sustainable from the delivery standpoint is very important. For vaccines specifically, there's a lot of funding from multiple different levels to help with making that easy process. But I think that's definitely something that we're constantly thinking about.
Okay, thank you for that. I know it's a kind of a big topic to ask as a 2-minute last question, but I think people are interested in your thoughts. So thanks very much for jumping into that. Thank you to you and to your students for what has been a really inspiring discussion today. And thanks to all of our attendees for taking time out of your day to join us. This is the end of the webinar. We have a few housekeeping reminders to cover before we end today's session. So I will hand it back to you, Shannon.
Thank you. Yes, thank you to our participants today for a great webinar. And for those in attendance, you will receive an email with a link to the webinar recording and a brief survey for feedback on the session. In addition, we'd like to ask for suggestions for other topics you would like to hear about in the future. Finally, please keep an eye out for an invitation to next month's Expert Insights series on COVID-19 and its impact on mental health among healthcare providers. Thank you again for attending. You may now disconnect. Enjoy your day.